Next on our agenda is the Primary Care Innovation Series, this time featuring Medicaid and the important part it plays in primary care. So this session is moderated by Kristen McGovern of Sirona Strategies, along with Hilary Hatch from Phreesia and Beth Lange as well. So take it away.
So thank you for hanging in with us. This is the last, I believe, the last of the market-specific innovation showcases. And, certainly last but not least, given that Medicaid is the largest payer here in the country, I think, or one of the largest, depending on which set of numbers you're looking at. So I am so excited to be joined here by my colleagues on the panel, and I will turn it over to them, just briefly introduce themselves. We'll do a little landscape setting on sort of the state of primary care and Medicaid, and then we will have what I hope to be a lively discussion, even though it's late in the afternoon, and we know that you're right here in the middle of all of the content. So go ahead, and Dr. Lange, would you like to introduce yourself?
Thank you. I'm Dr. Beth Lange. I'm a general pediatrician with 30 years of experience working in Rhode Island, and I really appreciate the opportunity to be a part of this panel, given that nearly 50% of the children in the U.S. are insured by Medicaid. While all the discussions up until this point have been about Medicare and Medicare innovations, I think we need to be very purposeful in this country about the innovations we put in place for children. Our return on investment is lifelong, and while that doesn't work in a traditional business model, it actually affects all the other business models that we're speaking of today. Because if we don't raise healthy children, we have very expensive Medicare participants. I don't know how many of you are aware of the ACEs study, Adverse Childhood Events. But it talks about, it's worth a Google, because it talks about how many of us have had childhood experiences that can be directly traced to chronic health conditions when we're older. So as pediatricians and family physicians who care for children, we really look forward to participating actively in these discussions to reform healthcare that makes our work feasible.
And Hilary?
Hi, my name is Hilary Hatch, and I'm a clinical psychologist, and I serve as Phreesia's Chief Clinical Officer. I'm really happy to be here today participating in this group and discussion. I've spent most of my career before coming to Phreesia working in safety net settings, and I then had the experience of really thinking as a behavioral health person, just seeing how many patients were actually in primary care with behavioral health problems rather than in a behavioral health office. And so wanting to see what could be done to bring tools to doctors and patients in that setting that could help them out. I started a company with some help from colleagues at Johns Hopkins, and then that company was acquired by the company I work for today, Phreesia. And what Phreesia does is we are best known for our digital check-in solution. Many of you have probably used it, checking in at a doctor's office. We check in 1 in 10 patients across the country today at 120 million visits. And what drew me there to a company that did very operational things that had nothing to do with anything I had done before was this idea that you had a person's attention in this moment right before they walked into the doctor's office. And how could you use that time to screen them for depression, to screen them for social determinants of health, to do developmental screenings, and so many things that could lead to a more engaged visit and save time and have a good patient experience. And so all of those opportunities were incredibly exciting for me. Most recently, Phreesia acquired a company called Insignia Health that has the license to the patient activation measure. So I'll talk about that today because that's a key component of my work in the Medicaid populations today.
Great. So before we get into the questions here, I think it is such a thrill for me as a DC-based policy person to talk to folks that are out there in the real world and who actually know what's really going on and whether the policymakers here in DC are getting it right or wrong, or the policymakers at the state capitals, as the case may be with respect to Medicaid. So I thought before we dove into some of the discussion around the specific innovations in Medicaid and some of the barriers in Medicaid to primary care innovation, we would start with just a little bit of level setting, and I won't bore you, but I did want to note, I would be remiss to be moderating a Medicaid panel without mentioning that we are at a really unprecedented time for the Medicaid program with the end of the PHE and the resumption of coverage determinations. So different states are in different places in terms of doing their redeterminations for Medicaid eligibility, but we are seeing in some of the states that are, fairly far along in this process, significant numbers of people losing coverage. And so this has always been an issue in the Medicaid population, churn in and out of coverage, but I think is very omnipresent here in all discussions on Medicaid, just because of the really, as I mentioned, unprecedented situation going on right now. So even just this morning, there were some numbers coming out of Florida. So 54% of the people that have gone through redetermination in Florida lost their Medicaid coverage. 82% of those were for administrative reasons. They got a form in the mail, or a form was mailed to them and they didn't return it back, or they didn't have a piece of paperwork or something along those lines. So that is definitely something, even as we talk about the clinical innovations, definitely something to keep top of mind as we think about the Medicaid program, and really sets it apart, I think, from Medicare and the employer market and other markets that we've talked about here today. The other thing I wanted to note just before we get started is that primary care really does play a unique role in Medicaid, and I think you'll hear that from some of our panelists. Medicaid has been a leader in primary care case management and the patient-centered medical home, and a lot of the value-based care innovations I think that have been mentioned and that will hear more about. So, certainly a lot of focus on the value-based care initiatives ongoing in Medicare, but we, again, would be remiss if we didn't acknowledge the very long history of innovation ongoing in the Medicaid market, and also to acknowledge that innovation is occurring despite what I think almost everyone agrees are very, very low reimbursement rates that, are very challenging for providers to work with. So the last thing I will mention is that although administration of the Medicaid program is a state and federal partnership, we have seen some federal rulemaking recently. There are 2 proposed regulations out there now that focus on access, finance, and quality. The primary care pieces to note, I just wanted to flag there is an element out there around payment transparency, so requiring states to submit an annual payment analysis comparing managed care plans, payment rates for things like routine primary care services. So that's an additional element of transparency that may be coming down the pike. And then another thing to mention are wait time standards. So one of the proposed rules includes a requirement that states develop and enforce wait time standards for routine appointments, including for primary care, but also outpatient mental health and substance use disorder and a number of other services. So definitely, even as the program goes through this sort of unprecedented time with the end of the PHE and some of the coverage issues happening, a lot of focus on modernizing the requirements in Medicaid, standardizing the requirements in Medicaid, and trying to improve the patient experience there. So sort of with all of that landscape in mind, I wanted to turn to our panelists. Like I said, for a DC-based person like me, it is a pleasure to have the opportunity to talk to people out there in the real world who see and live this every day. And so, I think I will start with our first question, which would be, what are the most promising primary care innovations that you're seeing in your work in Medicaid programs? And Dr. Lange, that would be in Rhode Island. But also, how are those initiatives improving access to care, quality of care, and health outcomes? So maybe we'll start with you.
Thank you. That's a great question. If I may build on your level set for just a minute, please, though.
Yes.
You're absolutely right. The stress is that Medicaid is a state and federal partnership, whereas Medicare is all federal. And because of the tensions in state budgets, one of the biggest things that gets cut first is Medicaid. And it's so short-sighted. For children, Medicaid crosses into special ed, early intervention. It crosses more sectors than just in the pediatrician and family doc's office. So at the federal level, if there's any way to shore up those funds so that states who are strapped are able to afford the Medicaid services they need to pay for. I looked at the new rules and find them to be contradictory in that transparency of pricing does not mean there's access for people to see. When Medicaid providers are being paid anywhere from 32 cents to 70 cents on the dollar, and 50% of children are insured by Medicaid, it is not financially stable for all of us to continue to care for these children. And I will guarantee you the wait times are going to be long, because they are right now and they're only going to be longer. So we need to fix A before we can fix B. And one of the fixes for A is the value-based contracting stuff that everybody's talking about. In many of the rooms I've been in, the participants have talked about the cost of pediatric healthcare, and we'll just divide it by 12 months, and that's value. Well, pediatric healthcare already is not paid completely. We do an awful lot of screenings and stuff that at the adult level would be paid for, but are not paid for in pediatrics. So when value-based contracting discussions happen, we need to think about the overall value of the care that's being delivered in an ideal world, not the current world, so that we don't codify and memorialize a broken payment structure. So thank you for letting me be on a soapbox for a second. I'm sorry that Chris Kohler is not here, because I'm actually presenting his work when he was our health insurance commissioner. He had the vision over 10 years ago that not, as you heard this morning, not spending enough money in primary care really disadvantages the health of people. And he founded an all-payer medical home, patient-centered medical home initiative called CTC Rhode Island, Care Transformation Collaborative Rhode Island. It started out with 5 practices with each of our insurers in the state in the same room, co-convened by our Medicaid director and the health insurance commissioner at the time, Mr. Kohler. So we had the absolution of being able to talk about contracts and monies without being afoul of the laws. And together they built a common contract platform where each of the practices was paid a management fee per member per month fee per every patient in the practice to be able to hire nurse care managers and then eventually care coordinators and social workers and dietitians. And it has built out a lot in the last 10 years. Always being the child advocate, Mr. Kohler will tell you very kindly, I kept badgering him every year and asked, when are children going to be a part of this? And very graciously, we were able to found PCMH Kids about 6 or 7 years ago. Things have changed a lot as they learned a lot on the adult side as to how children were going. And to my point of value-based purchasing and contracting, right from the get-go, we could not get our insurance companies to agree to the same per member per month charge payment that they gave the adult practices, even though our nurse care managers cost exactly the same to hire. So that is just the systemic challenges against pediatric care, because our return on investment is not 30 days. Nonetheless, we have persevered and we've continued to be creative. We have a fantastic partnership in Rhode Island with our Medicaid department, and we have been able to do one-off projects with our Medicaid department innovatively. At the beginning of the pandemic, our then governor, now Commerce Secretary, realized that children's vaccine rates were going to be behind in this pandemic when they couldn't get access to their medical homes. And so Gina Raimondo very quickly put together a grant through our ARPA funds, our pandemic funds, where we actually pulled in the Department of Health for data resources. We pulled in all the pediatric practices, and we put in practice facilitators to help teach us all how to use the data. And we actually brought our vaccine rates, they're up above pandemic levels in Rhode Island, and we've been able to renew that grant each of the last 3 years to have success with that. So we've had to be creative in order to make the payment for the services that we have in place, but with multiple partnerships, we've been able to do that, and we're scrappy because it's worth it. There's a phrase I heard many, many years ago in the AAP, and I'm looking at Dr. Perrin, who's one of the pillars of the academy, that said, all adults were once children, but not all children get to be adults. And it's a sobering reminder why we really have to be investing in children, because they truly, without being Dionne Warwick about it, they are our future. And so I appreciate the opportunity of everybody's incredible innovative thoughts that I have heard about this morning in the room, so that we can take care of children and their families in the way they deserve to be cared for.
Hilary, what about you? What are some innovations that you're seeing?
So I was thinking after the discussion this morning, because there were so many different ideas I had about things like a spotlight, bright spots around the country. We work in 50 different states across 3,000 provider organizations. But what struck me was something someone said this morning, and that I've been asked before. Where do you think patients are actually seeing a meaningful, noticeable difference in their care? That they say, wow, something changed from an innovation. And so if I ask myself that threshold fewer things really pop to mind. And not that the others are unimportant, but I'm going to spotlight those. So, I saw Dr. Roth here this morning from CCNC, and in North Carolina, working to help the state implement social determinants screening across the board in practices, I think is something patients are noticing. They walk into a visit, and in the best case scenario, and it's not always the best case scenario, but I'm going to tell you the best case scenario, they privately answer questions. They don't get asked by their high school classmate who's behind the desk, but they privately answer questions about social determinants. The person who receives those answers knows what to do with the information, knows how to get them to resources, and the data flows to the state. So I think the best, most meaningful situations are where we see that someone comes in, they get asked the right question at the right time, and we use that time really well, and we amplify whatever happens in that moment by not having the state then call them to ask them separately because they also need to know the information. I think in 2018, we probably on Phreesia did 100,000 social determinants screening, and in 2022, 4 million. So there's been a huge increase in uptake across all kinds of practices, not just North Carolina where it's required, in screening for social determinants. Another area that we work on a lot is incorporating the patient activation measure into programs, helping programs use it, Medicaid programs and other programs. But in that's an innovation. I would say that patients are seeing a difference when providers and the clinical care team is accountable for helping the patient develop knowledge, skills, and confidence to self-manage their health. And when patients feel that the clinician is actually invested in that, I think they notice a difference in their care. And so it changes how the model works. And it isn't, when patients come to a visit and a clinician says, I have to get this, see, there's this test score in A1C and I have to get that down. It's just, how does someone really understand, well, what's that going to mean for me in my life? It becomes kind of abstract. But when someone is really helping a patient understand their medications, know what to do when they're not sure whether to seek care or not, it makes a big difference to people. And I think they see that. And so some of the places, the bright spots that I see with that, South Carolina, it's not Medicaid, but it's the uninsured. They're not a Medicaid expansion state. So they go to the uninsured, they find those that are more than 5 ED visits, and they ask them social determinants questions. They ask them patient activation questions, and then they enroll them in an intensive care management program, and they've had extraordinary results. And I think people feel seen and really found in an emergency setting, and help to get to the resources they need and change. It's been particularly impactful in behavioral health and substance abuse hospitalizations and ED visits. So those are the areas that I think I would really focus on as meaningful examples where patients are noticing a difference.
So you mentioned a couple threads that I want to pull on as we continue the discussion. One of them is technology. So you mentioned the power of your platform to use for screening. So private screenings, you don't have to, like you said, say it to the person behind the counter you might know. You don't have to worry about people overhearing in the waiting room. So definitely, certainly some innovations in using technology for screening. We also, I think, as everybody knows, tremendous explosion in the use of telehealth and during the pandemic, and sort of we're recalibrating and figuring out what that means on an ongoing basis, but definitely more virtual care in the form of technology and remote patient monitoring. So could you say a little bit about what this looks like in the Medicaid program and how, the use of technology is maybe creates efficiencies or adds convenience, or even maybe there's some challenges for this particular population. I think we can't assume that their experience is the same as other patient populations that may have different different needs. This is a big one.
Okay, a big one and a lot of things to address and unpack there. I'll try and remember all of them. First, I want to say that while we can't assume that all patients have equal access to technology and can handle everything, I think one of the biggest mistakes we repeatedly make is to not implement technology because we say they won't be able to handle it. Oh, they're too old, too poor, too dumb, too something. And it's insulting. And, the truth is we're not trying to get the technology company should feel like we're shooting for 80, 90% of people using it. And that's a great objective. But sometimes you're just shooting for if 80 or 90 or 70% of people use it, you can go after the 30% with some other form of hand, like, face-to-face or whatever. You're just reducing the burden or limiting it to the folks that need it the most. So I always think that we can get really stuck on questions like that, whether it's rural or urban or Medicaid or anything. I think technology, where the most exciting thing I see about it is that we can achieve tremendous scale and we can give patients, put tools in the hands of patients and not ask the clinician that they always have to do everything. Everything that has to change has to go through the clinician. They have to sign the patient up for a mammogram or get them to remember every immunization. You can have things where patients are given the tools to be more responsible and proactive about their health. Not everyone will do it, but many will do it, and that'll help just motivate the system. So I think it can help with scale. I think it can help with resource allocation, because if you can get a whole bunch of patients digitally screened, you can save your resources for the few that need it. And with immunization is a great example. So if you can have a whole bunch of people self-schedule themselves for an immunization, you can reduce your call list to a much briefer list. And that, I'm sure your practice, like every practice has, well, maybe yours isn't on paper, but many are still just looking at a paper list. I got to reach my HEDIS goals. I'm going to call down this list of people. And the shorter you make that list, the more people are working to the top of their license. Those are the places that I think technology is making a huge impact. Oh, one more. Okay. One more. Self-reported data. So I think Purva said it this morning. This is so important. One thing that we see is that when people check in for their visits, one of the first things they look at is what is on file in their EMR as their race and ethnicity. And in 1 in 5 cases, it's either empty or it's wrong, and patients have the chance to correct it. And when we talk about trust and bringing patients along into feeling like they want to be engaged in their care, if that's in there incorrectly, it's really a profound turnoff for patients about why would I be engaged with this. So I think those are things that technology can do really well immediately.
So so pulling on another thread, we've already talked here about social need in this particular population. Dr. Lange, what role do you see for community-based organizations and other non-traditional healthcare providers?
Thank you. I think there's a tremendous role. Again, all of us intersect with every aspect of society. Again, my worldview is children. So we're talking about daycares and schools and after-school activities and parents, in addition to just general health. Within our PCMH Kids construct, we have built out a bunch of working partners. We now have community health teams that are able to help. We've kind of divided up the state into various regions where there's a community health team worker who can help interface outside of the medical home, but into the community. We've developed close relationships with our school nurse teachers. We all had to work closely together during the pandemic and how to get kids back into school healthy and safe. And we also have worked very closely with the Department of Health. Data is the key. I totally agree with you. And as more and more medical offices are part of bigger organizations or are employed by hospitals, the data is not getting down to the people who are working in the field. And so that's been one of our mantras, is making sure that while the health system may provide the support and the data mining and everything, we really need to make sure that the end user in the office knows, why are we doing these measures? We're not here just to give you a hard time, but it really is better health. And if you know, how can we work on different workflows to make it easier so we don't have to go back and recreate it? But I totally agree with you. I think there are multiple layers of people in the community that intersect with families and impact their health. And it's how it's important to engage them the best that we can.
I think it's sort of tying these two things together, the technology and community-based organizations, is that these are supports or a part of the primary care infrastructure in Medicaid. And so, you know, if you have great supportive CBOs and great data to power them and technology that helps, then the primary care system becomes stronger. But it's sort of making everything work together that I think is where the innovation lies, but also where some of the challenges come in. And we see that a lot, I think, in some of these cases with like behavioral health, substance use disorder, and some of the, you know, social services addressing social needs. So what would you say, so as you know, as you're thinking about some of these issues and sort of what we collectively need in the primary care setting to have a really well-oiled, functioning, high impact Medicaid system, what do you think is needed in terms of integration with, you know, some of these other supports? So whether it's technology or behavioral health or substance use or CBOs, what is really needed to sort of be the thread to tie everything together so that everybody can be sort of moving forward in a concerted way?
Thank you. I'll tie back to the example we heard this morning about the orthopedic office that had the extra revenue in their practice to be able to hire a nurse practitioner or family or physician assistant to pair up with the physician. Right now, with the current Medicaid payment rates, there is no cream in order to pay for the extra people that we need to have in a team. And there are multiple reasons why that's not the case. But being aspirational, which I clearly get that energy from this group today, the aspiration is we need to treat Medicaid like Medicare. I realize the legislation doesn't have the funding formula to be the same, but it does need to be resourced in a way that we can dedicate extra team members to work in settings. My office was lucky enough to just hire a social worker last month after a 3-year search. And it is just what she has done for our patients in just 1 month's time has been unbelievable. And to have that plus a care navigator plus a nurse care manager half-time already in just 1 month, we've been able to do so much more for our patients than we could before. And every office should deserve to have those resources. It makes my work life better, which means I'm going to stay in this job a lot longer. There was an article in the Boston Globe last month that talked about up to 50% of primary care physicians in the Massachusetts area are going to retire in the next 5 years. That's a startling number. We did a similar survey in Rhode Island, and it's 30% of pediatricians. Their people aren't coming to replace us. And so we really need to figure out the teams, not only take better care of our families who are going to have lower healthcare costs, but to just take care of the teams and to make sure that we can continue to do what we so much love to do.
So my next question is about some of the challenges, and we've talked about some of them, but I think it bears a little bit more discussion. So we've talked about state budget funding pressure. We've talked about low reimbursement generally. We just heard it took 3 years to find a social worker, and that there is, tremendous workforce shortage coming in the near term. Let's talk a little bit more about some of those challenges and other challenges that you see to primary care innovation in Medicaid. So what keeps you up at night when you think about these resources that you need that you don't have or don't see coming? Like, is the Calvary coming?
I think the Calvary is always coming because that's how I can sleep for a little bit at night. I have to believe that. And again, the energy of this room says that the Calvary is right here. What keeps me up at night, honestly, is just my patients. The fact that families have had such a hard time in the last 3 years, and making sure that we can all be present as parents and grandparents and physicians and office staff to be available for them. I think having the team that we had talked about, making sure kids have resources in schools, to help out. Obviously, that's not in the direct healthcare realm, but again, for the pediatric patients, schools is very much a part of Medicaid payments as well. Our early intervention team in Rhode Island has not had a raise in 20 years. Our nursing home workers have not had a raise in 15 years. And that's just not sustainable for a workforce. And so how do we, I mean, again, unfortunately, it all comes back to money, but it also comes back to innovation. And how do we use the people that we have with the money that we have to make sure that patients and families are safe and healthy?
Hilary, what about you? What keeps you up at night? What challenges do you see in terms of better supporting and enabling primary care innovation in Medicaid?
It bothers me that people aren't seeing the difference of all of our efforts, that's the most important thing, that people go to see, people love their doctors in general. I mean, it's part of the reason patient satisfaction is so hard to measure, because in general, I think people really, especially pediatricians, because they're like super lovable. But they do need, they need help there, and we want to see them find it. We want to see them not have a terrible experience getting it. But on the flip side of that, I think we just keep loading on to that visit more things that are not solvable within that visit. And so whether I remember, 10 years ago, oh my God, behavioral health, how will we ever screen for that? There will be nowhere to send people. And it's still a problem, but it's like primary care has taken on the burden of that. Social determinants taking on the burden of that. One of the things that I find sort of gratifying about patient activation and working on that with clinicians is they're kind of like, oh, this is something I can do something about. It's kind of, they can learn sort of simple strategies. I can, sort of figure out who's discouraged and really just needs the smallest possible step and a quick win and a little more frequent contact, and who's actually ready to take on more. And I've kind of been dumbing them down or keeping them from going the next step. And I think those feel like within the toolkit of what you can do within a visit or within a broader care team. And so I think trying to find things like that and knowing that, we're asking a lot of primary care. So ways that we can handle the workforce shortage has really forced organizations to use technology better, because there just aren't enough bodies to throw against, certain problems. So I think that's forced innovation, just like telehealth in the pandemic did.
If you could ask for one thing that would better support primary care innovation, what would you ask for?
I'm trying to think of a word that's not money, but
I'm not in your shoes, but I believe
it comes back to money.
Time.
It comes back to money
for their time.
There was an economist like 15 years ago that showed that for every dollar invested in children's health, $7 was returned to society. I'm sure those numbers are much more inflated, but we really need to invest in our kids. So if there's a way to make it work, I appreciate the tensions that happen at the state houses. I appreciate that some states chose not to expand Medicaid, so they have a whole nother kettle of fish of troubles there. But we just needed to teach the value as to why this money really does have a return on investment and why we really can't afford not to. As I've explained to our governor, it's great to have a healthy Rhode Island 2030 vision, but those people that you want in that workforce are in school right now. And when they're in the workforce, they're going to be making the money that's supporting your Social Security. And that's the collective view. I didn't say that directly to the governor. I wasn't pointing him out. But we really need to just put investments in.
I have another one. Since we have AAFP in the room. So I spend a lot of time.
Sean, are you listening?
It's not. Hi, Stephanie. So, we do a lot of work in kidney care, and we talk a lot about how could we end dialysis. Ending dialysis and the CKD work that Amy talked about getting people tested. All of that has to start through partnerships with AAFP folks. And, it's got to start not just in pediatrics, but the whole way through. in making sure that at every possible juncture, you've got someone sort of on the right track, and hopefully you're slowly moving them off that really bad trajectory. I talked to the American Diabetes Association this week, and they're doing an alliance to end amputation. Great, but I loved it. But we have to start very early with pediatric obesity to make sure that that doesn't happen.
So the value of primary care and annual or every other year visits to just touch base, to be proactive and anticipatory to things that may come at later years.
One more question, and I think then we may have a time, let's see, for the audience to ask a question or two. Our focus here is on Medicaid, but there are obviously interactions across markets and across payers. How can Medicaid programs work with other payers, maybe including Medicare or commercial insurers, to promote alignment and coordination of primary care innovation? So, all those great things that we heard about that are going on in Medicare, or all of the promise that we have for Medicare, how can we bring some of those same innovations to Medicaid, or modified versions of those innovations to Medicaid? And how can other markets support the work that you're doing?
I feel very lucky that in Rhode Island we do have PCMH kids in CTC Rhode Island, so we do have the ability to have all the payers in the room. We also are a very small state, so I realize that all of Rhode Island, I think, is LA County. So the ability to talk to everybody, we've just been able to do so many things just built because of those relationships. And I would hope that other even regions would be able to have a system where you can get all your players in one room and try and just align. We have different tensions, different profit needs, and different constituencies, but there are places for alignment. Just each region needs to figure that out.
I think someone said this morning the universal foundation of measures would make a big difference. I think not having clinician groups having to sort of answer different quality sets to different organizations, that would really help that alignment.
I'm going to ask a follow-up question because I actually just talked about this topic earlier today. The universal foundation, does that mean one set of measures to you? And does that mean, and when you think about it, do you think some of the measures need to come off the list? I know we've got long lists of measures across all programs. There's a lot of burden associated with collecting and reporting them. They don't match up. We just keep adding to the list. Do you think, what does it mean to you?
That's a complicated answer.
Yep.
So first of all, if there's...
That's why I'm phoning a friend here.
Okay. I'm not the expert in this, but so I'll be really simplistic about it. If there are 5 different, slightly different diabetes measures, having one, that helps. So that in terms of all the coding that needs to be done to capture the measure, digitizing measures, having measures so that you're not just paying some consultant to come at the end of the year and tally it all up, but it's happening. So Dr. Lange's being pinged when someone's missing an immunization as they're there. So it's more of a real-time
alert.
Those are the kinds of things that are going to make that real. So the redundancy, I think, needs to be thought about. But some measures are also maybe we need new measures. I mean, certainly we're very interested in the person-centered care category. So I think that's an area that's really relatively new, the patient-reported outcome performance measures, and really we need to look at and vet a broader range of those and pick ones that are really delivering, that are really outcome measures, not just process measures. So I do think that's what would make a difference.
All right, we have 10 minutes, maybe a little less. Any questions from the audience? We've got 2 hands here across the room. You might have to run, Sean.
I saved you. Yeah, I'm Lee Norman, and I'm a family physician, former secretary of Department of Health and Environment in Kansas. It's hard to talk about Medicaid without talking politics. And I had the misfortune of being secretary there for 3 years with a very red legislature and a Democrat governor. And we worked at it for 3 years. We did all sorts of very clever end runs to expand Medicaid in our own way, but still the state has not expanded Medicaid. Any tips or tricks from the political side of things to prevail on Medicaid expansion? I think there's 10 of us now, 10 states that is, that haven't.
I'll take this one. I think I don't think there's a silver bullet. I think that there are a lot of ideas that have been floated in terms of, sort of how to target the expansion populations in states that haven't expanded, but they really are hamstrung a little bit to state decision making and state legislative decisions. So I know I believe as part of one of the COVID bills, or maybe the end of a year bill last year, there was continuous coverage for moms and kids. So sort of save them from some of the redeterminations that are going on now. But that's not necessarily an expansion. And, I think that there's also been talk about creating maybe like a federal pool of dollars for Medicaid expansion populations in states where there's not an expansion. But that's a large undertaking. It's political, subject to the same political dynamics here in DC as many of you see at home in your states. So, no perfect answer, unfortunately. We've been trying to throw money at the problem, and in some states that's just not persuasive. So
I would say South Carolina is an incredible example where they've used what they call their, I'm looking at my colleagues here, I think it's called their Healthy Outcomes Program, HOP. And they use it to focus on avoidable ED, and they got grant funding around it. It's run by the university. It's definitely a way to bring resources to the population that would have been covered under Medicaid expansion in a state where they're really stuck politically.
Well, I also think a good MPH student job would be to look at the healthcare costs of uninsured people going to the ED or going to the ED late in care, and a very hard study to show that one causes the other, but unfortunately state budgets are spending more money than they need to, probably in ED or unavoidable care.
One more thing, that the way that they got money was that they went to the hospitals who were stuck paying the bills when uninsured patients kept hitting, and the hospitals lobbied to get that grant funding from the state. So it was same population that would have been in Medicaid expansion. You probably know of the program.
Another question?
Hi, my name's Tom Roth from North Carolina. We just expanded Medicaid last month, so it's possible. We're trying to be the wave that'll start to go south. It is possible, and it really was our hospitals driving some of that conversation and leaving money on the table and not wanting to redistribute money to other states, to blue states. So it's the political, after 12 years, it happened. So a question to Dr. Lange. In North Carolina, we've got a large group of about 500 practices, about half are pediatric, half are adult in a Medicaid ACO. And today we've talked a lot about value-based care and shared savings and these other ways to transform primary care. From a pediatric standpoint, have you seen models across the country that pediatric ACO models that really align incentives and work? In the adult world, we've got shared savings and quality. As you were saying, the time trajectory for kids is 30 years down the road sometimes. So can you comment on value-based care in pediatrics?
Thank you for the question. And in fact, your colleagues in North Carolina have been very inspirational to our work in Rhode Island. So we adore our North Carolina pediatricians. I don't think, I personally am not aware of anybody that's completely successful in ACO. I have two AAP colleagues in the room that might be able to comment on that. But I do know that in the policy rooms that I'm at least in, a lot of people are talking about how to do it. And it's not a one size fits all. But may I lean on my AAP colleagues? Do we know?
The concept is not a very good concept in the context of pediatric care. So we've done some work looking at a couple dozen ACOs that are pediatric in orientation, but the cost savings, the traditional cost savings, aren't really at that level. So in fact, in Massachusetts, we have theoretically implemented ACOs 5 years ago. And in reality, we didn't, but that's another story. But we actually are reframing with our new waiver to really have ACOs. And the ACO models there are designed around a somewhat different strategy for what the cost savings and returns are, including a very different sense of what returns are for the people 21. So Be glad to talk more. It's a complicated issue.
Thank you, Dr. Perrin.
More work to be done to develop a pediatric ACO model that works. Any last questions? I think we are at time. We could maybe have one more question, or else we can just wrap it up. All right, no more questions. We will just thank you for your attention. Don't forget about Medicaid, and turn it over to the next panel. Thank you.